an extremely important. We believe this is an extremely important subject to tackle. It is really a preventable harm that needs our attention. Anywhere you go, you will find this undesired outcome keep coming back again and again. And there are many reasons for this to happen. It's not going to be one answer, one solution. It has to be a comprehensive, holistic approach, nursing, RT, physicians, everybody. But it's really sad to see when you're trying to help our loved one and we end up with permanent damage to their skin. And sometimes technology can help us a lot, but we believe the skillful nursing RT are the most important element to minimize, inshallah, in the future to eliminate this unwanted preventable harm. I really thank Aqil and Carlos and Afrah for taking the time to be here tonight. I also appreciate every single one of you to be in this meeting. It means you really care about your patients, and I don't think this should be one-way kind of presentations. You could also use the chat, send your questions, write your comments. Someone will read it. Hopefully they will share it with Aqil. Aqil will go through it with the speakers later on. So let's try to put it as much as an interactive session as possible. We know some of you are just coming from duty, others are going to duty. So really your time is very important to us. Technology and those kind of things always happen. When we go and see it all over the place, sometimes minor issue happen. I think with Carlos, you might send your presentation to Afrah. Afrah can share it after, and then you can tell her to move the slides for you, or you could share it with Aqil. Any one of them has an access and can share their screen. We will be looking at the chat for now until they get ready, and maybe Zahra and whoever is following the chat can share with Aqil all your concerns. I believe there is also an attendance link will be sent later on. You can access it and attend. We promise you, inshallah, through the Critical Care Society Respiratory Chapter, we will be doing more webinars. We will be doing it based on your suggestions. Please follow our Twitter, all the social media there. Join the Critical Care Society. We are volunteer to help the profession, share the knowledge we have in our facilities with the entire nation. We welcome you. You could contact me right away. You could contact Aqil, anyone you want, and share with them your concern. We thank you, and I would leave the mic for Aqil for now. Hopefully, inshallah, Afrah is ready, and we will, inshallah, start soon. Shukran jazilan. Allah yuwaffiqkum. Thank you so much, everybody.
Thanks, Mr. Salam. Shukran jazilan, ma qassart. So we're going to start now, inshallah, with Mr. Carlos. Mr. Carlos, are you ready? Mr. Carlos? Mr. Carlos? Yes, you can join, Mr. Carlos.
يمكن ما يقدر يا عقيل عشان من جوال يعني. حاول البرزنتيشن عندك.
Okay, we are sorry for that one. خلاص. I think we will jump to the next speaker till Carlos takes the issue. I think he's facing really trouble with the
It's okay, we'll
joining
get
us.
it.
Yeah.
أفراح.
Let's welcome the second speaker, Miss Afrah Ubaidan, master degree and registered respiratory therapist, registered adult critical care specialist, and registered neonatal pediatric specialist, senior respiratory therapist too. So welcome, Miss Afrah.
Thank you, Mr. Aqil, for the introduction, and thank you everyone for coming to this webinar, and I appreciate everybody's time. This is an important issue, and I appreciate everyone being here for this webinar. So I hope everyone can see my screen. Can you see the screen, Mr. Aqil?
Yes, Afrah. Everything is well.
Okay. So in my part, I'm going to talk about the prevention of endotracheal tube-related pressure injuries and guidelines to prevent pressure injury for patients in prone position. And our objectives here are to identify strategies to prevent ETT-related pressure injuries and strategies to prevent pressure injuries in patients placed in prone position, and how to apply these strategies. So we're going to start by talking about why pressure injuries, or why this topic is important in the first place. So HAPI, or hospital-acquired pressure injuries, are now being recognized as a quality indicator for the organizations. And so the organizations are really focusing on their HAPI as a key quality indicator. And so this change actually came from when the Agency for Healthcare and Research Quality identified a reduction in avoidable patient harm between 2014 and 2017. So there are certain avoidable patient harms that showed a decrease within this period. However, HAPI actually showed an increase. So even though HAPI can be avoided, it actually increased during this period. And it's also in the literature, medical device-related pressure injuries has been shown to prolong hospitalization, increase cost for the healthcare cost, and can also increase the morbidity and mortality. So that's why we need to look at strategies to prevent this type of complication and this type of pressure injury. So where are we right now? What is the situation? Is that among all the devices that can cause pressure injuries, the ET tube holder, or the ET tube fixator, is actually the most common device, the device that is associated with the highest incidence of pressure injury. So almost 45% of pressure injuries are caused by the ET tube holder. So again, we really need to look at strategies that can help us prevent this injury when using these devices. To look at, or to find the best strategies that can prevent ET tube-related pressure injuries, there is a systematic review and meta-analysis of 5 RCTs, or 5 randomized controlled trials that compared 3 types of ET tube holders. The anchor fast, Hollister, or what it was previously called the ETAD, the twill tape, and then the adhesive tape. And so they compared all the 3 devices in terms of their incidence or their risk of developing pressure injury. So they looked at the incidence of pressure injuries in the perinasal area and the perioral area and the oropharyngeal area. And what they found is that the anchor fast Hollister device was actually associated with the lowest incidence of pressure injury the pressure injury incidence decreased by 76% in patients that used the Anchor Fast Hollister. So when we're trying to select which type of ETT tube device that will help us prevent pressure injuries, we need to consider using the Hollister or the Anchor Fast Hollister device, as this device can actually help prevent pressure injuries. So the authors in this study contributed the reduction in pressure injuries to different reasons. First is that the Anchor Fast device can allow easier repositioning of the tube. So it's easy to adhere to the intervention, which is repositioning the tube every 4 hours as a prevention strategy. So it's easier for the staff to adhere to this intervention when using the Anchor Fast. Another reason why the Anchor Fast, or why they attributed the reduction in pressure injury, was that the Anchor Fast also allowed easier assessment of the lips and the oral mucosa. So it's easier for the clinician to assess these areas when the Anchor Fast is used. So these are interventions that we need to do, or that we should be doing to when we're using a tube holder. And so the Anchor Fast device it makes it easier for us to adhere to this intervention. And so that's probably the reasons why the pressure injury incidence decreased when using the Anchor Fast. Another reason also is that there is an easy access for oral care. It allows easier access for oral care, and there is also other advantages with Anchor Fast, that it can potentially decrease the time for management of the device. So it can potentially save the clinician time, because it's not going to require as many changes as the other devices do. So with the twill device, with the twill tape and with the adhesive tape, they're going to require almost daily changes. However, with the Anchor Fast, the recommendation is to change it about every 4 to 7 days. So this is another advantage when considering using the Anchor Fast as a ET tube holder. Now, the caveat for using an Anchor Fast device is that you cannot use it for pediatric patients. So there are limitations to using that device, and we cannot use it for pediatric patients. There is a high risk of developing pressure injuries in prone patients when using the Anchor Fast. And it can be also more expensive. So there is a lack of an economical study that looks at the cost and outcomes of using the Anchor Fast. So there is a lack of the study that shows that yes, the cost of the device can be offset by the outcomes that we can accomplish with this device. There's no study yet to be published. There are other preventive interventions that were also in the literature, that were also studied in the literature, and these are more frequent changes or more frequent repositioning of the tube. So most hospitals or most organizations use the intervention of changing the position of the tube every 12 hours. And this, in 2 studies, they actually looked at more frequent changing of the repositioning of the tube. So if we reposition the tube more than 12 hours, so like every 4 hours, would that also contribute to even less pressure injuries? So in these studies, they were not able to find any benefit for this intervention. So changing the tube every 4 hours versus changing the tube every 12 hours, there is no difference between the frequencies. So the recommendation was to change the tube or reposition the tube every 12 hours. They're also looked at other intervention, like more frequent changes of the device. So, for example, again, the recommendation in the literature, or most most hospitals recommend using or recommend changing the ATAD or the anchor fast every 7 days. And in this study, they looked at changing the ATAD or the anchor fast every 4 days. And so they compared the difference between changing the ATAD every 4 days and changing the ATAD every seven days. And they also found no difference between these frequencies. Also, they looked at more positions on the lips. Also, that intervention was not associated with less pressure injuries. And they looked at using a towel to lift the endotracheal tube, using the towel on the patient chest to lift the weight of the endotracheal tube. Also, that intervention, they didn't find any benefit for using that intervention. So these are the other preventive interventions that were looked at in the literature and their outcomes or their results. When comparing the twill tape and adhesive tape and their effect on developing pressure injuries, there is a randomized controlled trial that compared the two devices, and the randomized controlled trial, it was shown that in this randomized controlled trial, it was shown that the twill tape is actually superior to the adhesive tape. It causes less pressure injuries. And then if you want to take a step further in your the preventive interventions, you can actually use a silicone strip under the twill tape, which can actually prevent the facial pressure injuries. These are the strategies that you can use when you have two options, a twill tape versus adhesive tape. The twill tape will be superior. For factors that can increase ET tube related pressure injuries, Musa in her study found that vasopressor infusion is actually associated with six-fold increase in the odds of developing ETT. So if you have a patient that are on vasopressin or on norepi, these are actually at higher risk of developing pressure injury, as these two pressors are associated. They are strong predictors of developing pressure injury, and vasopressin is actually a stronger predictor than norepi or levofed, and so we really need to be vigilant if you have a patient with and these they have vasopressor infusion, then you need to be vigilant in your assessment. So maybe conduct more frequent assessment than you would with a patient that doesn't have pressor running. So this is one of the factors that will increase pressure injuries in patients with endotracheal tubes. To assess the stage of pressure injury or the grade of pressure injury, there is a tool. It's called the Oral Assessment Guide, or OAG score. That's the tool that is used in the literature. And you can use this score. It has a grade between 1 to 3. And then you can use it to assess the oral mucosa. However, there are no descriptors, so you're not going to be able to assess the face with this tool, but you can use it to assess the oral mucosa. And again, it has a scale between 1 to 3. For nasotracheal tubes, the strategies that have been studied to prevent pressure injuries for patients that have nasotracheal tubes is the use of hydroactive and hydrocolloid dressing. In the studies in two high-quality randomized controlled trials, they found that the use of hydroactive or hydrocolloid dressing under the tube can actually prevent the development of pressure injury on the nasal ala. And so this is one of the recommended interventions if you have a patient with a nasotracheal tube. For patients in prone position, there are specific guidelines for patients in prone position, as these patients considered to be at high risk. In fact, the pressure injuries actually has been reported to be that's to have the highest incidence among the all the other complications of prone positioning. So patients in prone positioning, yes, they are at risk of unplanned extubation and dislodgement of the tubes and other complications. However, the risk of developing pressure injuries in prone position is higher. So they are at higher risk of developing pressure injuries. So we really need to adhere to the intervention and strategies that are reported in the literature to avoid this complication. And so among the locations or among the areas that can develop pressure injuries in prone position, the face was the most frequently reported area. And so there are also other areas, so as shown in this picture. So there are other areas that can develop pressure injury when in prone position, again, as shown in this picture. So we really need to pay special attention to this area when we apply our strategies. As far as guidelines to prevent pressure injuries in prone position, I have to mention there is a plethora of information out there. So as you can see here, there is this is a list of protocols and guidelines that are available online. And as you can see, it's a very long list of guidelines. And so at the end of the day, it comes down to the organization itself and the institution itself to, and whatever resources they have and whatever the skill and experience of their staff, it comes down to the institution to develop their own guidelines and their own protocol. So this is, yes, a pretty long list. However, there is no single document that contains all the evidence-based practices that is free and that is available to access by everyone. So there is no single document that contains all the evidence-based practices for patients to prevent pressure injury for patients in prone position. So again, it comes down to the institution to develop their own guidelines. In this talk, we're going to focus on the national and European pressure ulcer advisory panel guidelines, the clinical practice guidelines from this advisory panel. And this panel or this clinical practice guidelines focus on four main things: risk and skin assessment, using support surfaces to offload the pressure, and then using prophylactic dressing for medical devices and for bony areas. So the first component of these guidelines is risk assessment. So we're going to assess the factors that can increase the risk of developing pressure injuries. In this case, the patient is going to be in prone position, or the patient is in prone position, so they're critically ill, they're probably in vasopressors. The duration of pronation is also another factor. Age also is another risk factor that can that should be considered. So we need to assess their risk of developing pressure injury. We can use tools like the Braden scale to predict the risk. This is a tool that we can use that is widely used in the literature, and that is also recommended by the panel. As far as skin assessment, that will entail conducting a thorough and comprehensive assessment, a head-to-toe assessment, prior to the prone position or prior to placing the patient on prone position, and after flipping the patient back to supine. So after we reposition the patient to supine, we need also to conduct our assessment. We also need to check the skin under the medical devices. So if it's possible, we need to remove the device, remove the dressing under the device, and assess the skin under the device. So for skincare, we need to, the panel recommends using a cleanser that has a pH between 4 to 7. So we're going to perform skin hygiene and skincare before we prone the patient. And so the recommendation states that we need to use a cleanser that has a pH between 4 to 7. as this has demonstrated this has been demonstrated, the pH, the cleanser that has a pH of 47 can actually decrease the incidence of pressure injury, as was demonstrated by the Park and colleague. So after cleansing the skin, we need to apply a moisturizer. There are no recommendation regarding the type of the moisturizer. However, there is this, and in this RCT or in this randomized control trial, Otero found that the application of hyperoxygenated fatty acids actually can decrease the development of pressure injuries from the non-invasive face mask. So after cleansing the skin, we need to apply the moisturizer, and the type of the moisturizer we can consider using the hyperoxygenated fatty acids, as it has shown to decrease the incidence of other pressure injuries. We can consider using this moisturizer for patients in prone position. So the third component that we need, that is part of the guideline, is using pressure redistribution support surfaces. And the guidelines or the panel recommends using either polyurethane foam or neoprene air-filled foam pillows for this purpose. So we're going to use these types of pillows, this specific type of pillows, under the pressure points areas that we looked at earlier in the presentation. So these pillows will act on offloading the pressure and offloading the weight of the patient, these specific types of pillows, and will help prevent pressure injuries by that mechanism. So again, the panel recommends either the polyurethane or the neoprene air-filled pillows to offload the pressure. For the panel also recommends specific type of mattress that should be used, and then the donut-shaped positioning devices should be avoided per the panel recommendation. The last component that we're going to address here, the last component of the guidelines, is to use prophylactic dressing. And we're going to use prophylactic dressing under the medical devices. And again, we're going also to focus on the pressure points that are at risk of developing pressure injuries. And then when we select the type of dressing, we need to pay attention to the type that we're going to use, because sometimes some types of dressing are going to be ineffective. We really should be using silicone multi-layered foam dressing for this purpose. So this is the type of dressing that has been shown to be actually effective. And so this is to show you that the effect of using silicone multi-layered foam dressing on reducing the pressure and reducing the facial pressure when a patient is in prone position. And so Pico and colleagues, what they did they actually measured the stress and strain when the patient is placed in prone position. So they measured the energy, stress, and strain, and they were able to find that the strain and the stress was actually significantly lower when they apply silicone multi-layered foam dressing. So the pressure, the Meplex specifically, so the foam dressing, the Meplex specifically was, they were able to show that it can reduce the pressure, the facial pressure, when the patient is in prone position. For the frequency of repositioning the patient, there are no recommendations regarding the frequency. However, in the literature, it's been reported that every 2 to 4 hours repositioning can actually be effective to prevent pressure injuries. And lastly, I want to just say that prone positioning can actually be done safely and with less complications if it's performed by a trained and experienced clinicians. So as this was demonstrated in the Perceiva trial, they had lower complications than any other studies. And one method that you can use to actually train your staff in prone positioning is the method that Dr. Brady Scott and I looked at in this study. So what we did is that we used real humans and we attached tubes and catheters and IVs and ECG leads. And so all the tubes that would be attached to an ICU patient. And we had the participants prone and turn these patients. And what we found is that when we used real humans along with our intervention, actually we were able to increase the participants' confidence and knowledge of prone positioning. So this is one method that you can consider when you're trying to train your staff in prone positioning and how to prevent complications of prone positioning. And with that, here are my references. This concludes my presentations. I guess we'll have questions at the end.
Thank Ms. Afrah for this nice talk. It was really amazing. So, dear audience, if you have any question, just raise your hand or write it in the chat while we are coordinating with Ms. Carlos. Any questions, please? You can write it in the chat. Then we will go back through it to be answered by Ms. Afrah. Mr. Carlos?
Hello, good evening again. You can hear me now, I suppose?
Yes, I can hear you well.
Well, let's see if I can now share my screen. Once again,
Okay.
I apologize for the technical problem before. You can see my screen now?
Yeah, perfect.
Okay, good news. Okay, so let's start from the beginning. Let me once again apologize to waste your time, and for this technical problem. It's always bad when technology doesn't help us, and well, of course it's the human fault, not the technology. The machine is always right, but I couldn't make it at that time. So let's proceed. My name is Carlos Pereira, as was presented in the beginning. I'm nowadays a project lead coordinator in clinical strategy department in National Guard Health Affairs. My background is nursing. I have a bachelor in nursing, a postgraduate in nursing rehabilitation, a master in health administration, and executive master in international business. I was before working in the wound and ostomy care team, where I was working in straight collaboration with the respiratory therapists, and like to say and to appreciate all the efforts from the respiratory therapists, and it was an amazing work. And as said in the beginning of this presentation, only with a collaboration, only the collaborative effort, we will succeed on this. It's not only nurses, only RTs, no, it's together. So I will present you the pressure injury physiopathology. If I'm speaking too fast, let me know, because now I'm a little, don't want to take it too much time. Let's proceed. After that, I will speak about pressure injury staging, how to stage a pressure injury, what's the differences. I'll speak a little bit about medical device related pressure injuries, which Afra in a such nice way and in a so complete and comprehensive way. And in the end, some interventions, very brief interventions related to a non-invasive ventilation, specifically by PAP. So proceeding, what's a pressure injury? This is the National Pressure Injury Advisory Panel definition. It's a localized damage to the skin and underlying soft tissue, usually over a bone prominence or related to a medical or other device. And how does it happen? What are the causes of pressure injury development? Well, mainly pressure, of course, on the soft tissues between usually the surface and the bone of the patient. So basically the weight of the patient is compressing the soft tissues against the mattress and leading to a reduction of the nutrients and oxygen supply to those tissues, leading, of course, later on, if prolonged exposure of pressure to that. You can see in the picture that the bone with the weight of the patient compressing those vessels, those soft tissues, and under you have, as explained. But there is other contributing factors like friction, like shear forces, and moisture, where we can see in this diagram that friction is when for example, your skin slides the mattress. That's friction, and the skin gets irritated. And of course, in a normal person like us, a healthy person, sorry, it will make no difference probably. But in a sick patient with high temperature, with fever, with low blood perfusion, it is enough sometimes for the skin to get irritated and later on to develop further injury. Shear forces is when instead of sliding, the skin gets somehow stuck, and it's the inner tissues, the inner exactly, the inner tissues slide against each other, the subcutaneous tissues, I wanted to say, sorry, and leading it to micro injuries that will again result in a lack of supply of nutrients and oxygen to the surrounding soft tissues. And the moisture, they gets the skin very sensible, and of course as well is another factor that will expose the skin easily to development of pressure injuries. So proceeding to the staging, there is 4 grades to classify pressure injuries: stage 1, stage 2, stage 3, and stage 4. And those pressure injuries, those stagings are classified according to the depth, according to the amount and type of tissues affected. As possible to see in this right side picture, we have the dermis, fat tissue, under muscle and bone, and tendons in the middle, of course. And according to which layer is affected, we will stage our pressure injury. So a pressure injury, as I said, that is for the stage, and that is 2 temporary classifications, which we only use because we cannot clearly and confidently say which layer of the tissues were affected. So the stage 1 pressure injury, the skin is intact. It's addressed as a non-blanchable erythema, where it presents as a redness. And how to distinguish if is it a simple redness or if is it an injury already with the blanching tests. Okay, basically we press the skin and if the skin gets whitish, if it blanch when we press finger, means that it's not a pressure injury because there is still blood supply to those surrounding. And when we relieve, almost instantly it will become to red again. If it doesn't change, if it doesn't blanch, it's a pressure injury because there is no blood supply, so it won't make any difference. And in this case, there is no open ulcer. Okay, as I said, skin is intact. Is as well important to feel the tissues, even mainly, for example, in dark skin colored people, because you will not as clear realize this changing in the coloration. So you need to feel the tenderness and the temperature because it will change as well. So you have here some examples. For example, in this case, in the heel of the patient, it looks like a stage 1 pressure injury, but we would clarify only if we do the blanching test, if we press to see if there is a refill of blood or not. Here another example in left buttocks of a patient, and same situation. Stage 2 pressure injury. Stage 2 pressure injury is partial thickness skin loss, and in this case, the epidermis, or both epidermis and dermis, were affected, but there is no complete layers of skin lost. unless it's mixed etiology, for example, together with a moisture lesion. But the pressure injury itself, because as I explained, is due to pressure, is due to this lack of blood supply to the surrounding tissues, it won't bleed, and it's usually demarcated. It's frequently in a circular shape, unless related to medical devices, as we will see later on. And stage 2 pressure injuries doesn't have necrotic tissues. It's very superficial. Usually no, we will not distinguish the skin layers. It will look very shallow. And here we have some examples. You can see that it's very superficial. It happens usually over bony prominences like the trochanter of the patient, in the sacral area, ears. In the case of the BiPAP, it might happen, for example, in the nose. Another example, you can see reddish but not bleeding, and it's shallow. Usually it is a regular circular shape. It might be as well a blister. If it's a blister over a bone prominence fulfilled with whitish fluid, it's as well a pressure stage 2. It means that this layer of between the epidermis and the dermis, or dermis with subcutaneous tissue, was affected, not fatty tissue or muscle. So if it would be dark with fulfilled with blood, that would be a different story that we'll address later on. But whitish like this presentation over bony prominence on locations of pressure. Of course, if you have a patient that were never prone, then to suddenly develop a blister on his chest without any medical would justify the pressure. It's not probably a pressure injury, but over a trochanter, over a sacral, with a patient that was in those positions in a lateral or supine or under a BiPAP and develop a blister, yes, it's a stage 2 pressure injury. Stage 3 pressure injuries. Stage 3 pressure injuries is full thickness skin loss. It is starting to be a bigger injury, forming some degree of cavity depending on the amount of fatty tissue that we have. In this case, as I just said, it's fatty tissue that is exposed. It might have necrotic tissue. It might have fibrin necrosis. The edges are rounded, and it's possible to see the full length of the skin. It's possible to see completely the skin and the fatty tissue under, not muscle, not bone. Okay, in that case, it would be stage 4, as we will see later on. See these edges of these, comparing with the pictures that you saw before. Here we see clearly the skin layers, and we see some slough, some tissue on the wound bed. So we have here some pictures, another one similar as the previous one, circle shape. Here the wound bed is almost totally clean, but then you can see there is some moisture in the surrounding edge of the ulcer, but you can see the layers of the skin clear, shallow anymore like in the stage 2. And in the right side, even though it's shallow, even though you don't see the edges of the skin, as I said, stage 2 doesn't have necrotic tissue, doesn't have a fibrin or slough. In this case, it's totally covered of slough, is a yellow slough. So let us know that it's not going deeper to the muscles or to the bones, because otherwise we would classify it differently, as I will explain later on. But in this case, because it's very shallow, it tells us that it's very thin layer of fibrin, so it's stage 3 pressure injury. Moving to the stage 4, the last stage, for instance, it's again as well full thickness skin loss. And of course, in this case, as you might imagine, is forming a deeper cavity. And it's quite frequent. It might have, and it's quite frequent to have necrosis or black tissue. Bone, muscle, or tendons are exposed, not necessarily the 3, but at least one of them. It's common as well to have undermining and tunneling. As I said, it's usually a bigger cavity, a bigger ulcer. that is, as possible to imagine, extensive destruction of the soft tissues. And we have some example here. I hope no one will get too much impressed with the pictures, but you can see here clearly that all the layers, even the fatty tissue, is already gone, and we see undermining there. We don't even know where is it going, if it's going until the bone or tendon. We clearly see that there is muscle and it's a big cavity. Here, I brought intentionally this picture because even though it looks quite small thing and it's a kind of pressure injury that happens very frequently due to medical device and specifically respiratory medical device like the BiPAP, because of the TAP, this is a stage 4 pressure injury because there is the cartilage exposed. Okay, so I said in the beginning that for example, in the case of the stage 3, depends the size of the cavity on the amount of fatty tissue that we have. Imagine in the here and I'm bringing the here in, like for example, it happens the same with the nose. We have very thin, almost inexistent layer of fatty tissue. So that's why that very quickly, and also on those locations, a pressure injury will become a stage 4. Moving further, we have the 2 temporary classifications that I mentioned before, the unstageable and deep tissue injury, pressure injury, DTI, usually known as DTI, and those are temporary classifications. The fact, as I said, that it's not possible to observe and properly stage pressure injury. We cannot distinguish in the case of either the DTI. In the case of the DTI, the skin is intact and usually presents as black or purple. And this black means that there is blood. So comparing, for example, with the situation of the blister that we spoke before, that it's a stage 2, in this case, it tells us that there is vessels involved, big vessels, and there is blood that is dead under this injury. So you can see small picture that it might go, usually the damage inside is bigger than what we can see outside. And that's why we call it DTI. If it's an open ulcer covered with eschar, with black tissue, as you can see, that black side there, it's going until to the bone, but we are not sure if it will stay in the yellowish part, as you can see there, those layers, or if it's going to the muscle or to the bone. It's full thickness. In this case, there is destruction of tissue, open ulcer, comparing with the DTI, but we cannot distinguish if it's a stage 3 or a stage 4. There is here some pictures, some images to distinguish. This is typical DTIs on the heel of the patient. You can see presenting as a purple or a black. And in these 2 cases, I would say that probably the damage is down to the bone. But as you can see, the skin outside still presents as intact, but later on this will open and with unstageable, this is the deep tissue injury, as I said. With unstageable, usually a little bit more like this. And I said before, with the stage 3, you saw that it was totally covered with yellowish tissue. So that fibrinous tissue, that yellow tissue, was telling us that this necrotic no more. This necrotic is telling us that is going deeper, so much probably more than the fatty tissue, but we are not sure. So we cannot clearly and confidently classify it, so we will say that it's an unstageable. Okay, moving further, medical device-related pressure injuries. According again to NPAP, it results from the use of devices designed and applied for diagnostic or therapeutic purposes. The resultant pressure injury generally conforms to pattern or shape of the device. And here there is, before, usually pressure injury as the shape, the circle shape, okay, demarcated circle shape. In the case of medical device related pressure injuries is totally different. It will imitate, it will mirror shape of the device that is applied. For instance, let's take this example. Let's Foley a catheter IV line that it's under patient, under the patient weight. It's being squeezed between the patient against the mattress, and probably again in a healthy person, this will not make much difference. It will be probably printed as well in the skin, and it's sometimes with even your clothes, but it will not make an injury, and later on it will, after a few minutes, become to normal. But in a sick patient, this might be enough to do a pressure injury. And it's the same concept with the respiratory devices, with the BiPAPs, with Gs, with well, the different medical devices that we can apply for respiratory purposes. And this happen, or this is not caused, but a contributor making the patient more exposed to this problem is the sensation impairment. For instance, the patient might communicate, and in our case, if we feel this, we will feel pain, and we'll let you know, okay, I'm feeling pain. This BiPAP is causing pain in my nose bridge. But because of these sensory impairments, the patient will not let you know, so it will develop an injury. The excessive moisture as well. This is, as I said in the beginning, a contributing factor to develop pressure injuries. Poor perfusion, again, same. Poor nutritional status. Is very important that the patient is hydrated and that it's eating properly. In the case of critical care patients, that the of intake, and here is important again, collaboration. We spoke about collaboration between nurses and RTs, important as well to involve nutritionists to make sure that the patient is having the necessary intake. And edema. And there is one kind of pressure injuries that Afra spoke and that I didn't address in the staging, that doesn't follow those staging system, which is the mucosal. Mucosal pressure injuries, which, for example, an ETT tube will cause on the lip of the patient. It follows different rules because the tissues are totally different. It's not normal skin, so we will simply call it mucosal. In the lip, in the tongue of the patient, inside of the oral cavity, the penis, for instance, in the gland, let's say, inside of the nose of the patient, due to, for example, nasogastric tubes. Those pressure injuries are called as mucosal, as Afra addressed before, and yeah, that's it. As I said, with the sensation, same process with the communication of the patient. Let's say that the patient is feeling the pain, and so, well, for sure, all of you witness agitated patients in critical care and might wonder sometimes, why is this patient agitated? Eventually might be pain. The patient might be feeling pain and cannot express this, and, well, agitation is the way. So this is very important for something that was already said, to use critical thinking. Okay, each patient is one patient, none are the same. The interventions are not the same. They don't feel things the same. So we need to use this critical thinking to realize, to understand what is happening with our patients. Another common sense, and in this case, a common scenario in critical care patients, and as I was saying, just use common sense, just use this critical thinking to address those situations. Another why this happened, beside these contributing factors, we have the wrong size. Sorry, it's wrong size, not wrong side. It could be side as well, because if we apply it improperly, of course, it would be as well contributing, or it will aggravate the situation. But in this case, wrong size of the device. If we put a too small medical device, for instance, speaking about the BiPAP, it will probably cause more pressure to be applied properly. If we put one too big, eventually we will need to tie it stronger to try to not have leaks and to have the pressure, the settings that we want or that it's recommended, prescribed. So it will, of course, have more predisposition to develop pressure injuries as well. Not correctly placed, as I said, the site, if not correctly placed, it will probably not distribute the pressure. Let's take again the example, and I'm mentioning the BiPAP because ETTs and BiPAPs one of the major cause inside of the respiratory device related pressure injuries, the ones that are the most to develop pressure injuries, and the rates of pressure injuries in worldwide in all the hospitals. So taking this example of the BiPAP, if we place it properly, the pressure at least will be redistributed on the face of the patient. If we don't, let's for instance say we don't apply it and it's doing more pressure in the bridge nose, the nose is a small spot to handle all that pressure with a little thin fatty tissue to absorb the amount of pressure. If we distribute it properly, for instance, the cheek of the patient has some little thicker layer of fatty tissue, and it will help us on distribute the pressure, in this case, not having this higher predisposition, higher risk to develop pressure injuries. With the skin, Afra spoke as well about the repositioning medical devices and as well repositioning patients, and it's important to not leave the device too long, and I would take this opportunity to mention that even though, as Afra said very well, that evidence shows different recommendations in terms of changing medical device. Usually in the hospital, in National Guard, we recommend, but the most important it's taking in mind is critical thinking. So proper size of the medical device of the BiPAP, for example, with I will speak about it as well, but moving further, applying hydro or some gel pad, and we apply it properly, not to correct size. The patient is quite stable. I would say that it has the perfect conditions to stay longer. No need probably to change it every 4 hours. But if we have a patient that it's a little bit less stable, let's say, and the BiPAP eventually it's not the correct fit to that patient because we don't have other options, other interface to change. We need to tighten it a little bit more to have the correct pressure. In that case, I would say that better to check the skin more often and reposition it and let the skin breathe more often as well. And this links to what I'm saying right now, the lack of observation. It will always start, it never jumps directly to a DTI or to unstageable or stage 4. It will start as a redness, a simple redness, an erythema, later on a stage 1 pressure injury, and only then it will rupture and become a stage 2 pressure injury. So if we capture it while it's red, an erythema, perfect, wonderful. We will just relieve the pressure for a while if possible, if the condition of the patient allows us, and it will simply disappear. Even if it's a stage 1 already, if we let rest, there is some evidence saying that after 8 hours it will reverse, depending of course in the level of injury degree and the conditions of the patient to recover, for instance, the hydration and nutrition status, and if fever and infection, everything, it will disappear, it will reverse. So this is a critical moment to catch these pressure injuries. And which devices? cause it? Well, endotracheal tubes, as we saw from our presentation, with the respective supports, even though the anchors are amazing, it's really wonderful to fixate, to not have accidental extubations, and to try and prevent pressure injuries on the corner of the mouth. So, for example, it allows us to reposition the ATT very easily. Still, we need to be careful. We need to apply it properly. We need to be vigilant and to observe the signs of pressure injury. Tracheostomies, BiPAPs, high flow nasal cannulas, from the most complex one like the invasive endotracheal and tracheostomies to BiPAPs, high flow face masks, and nasal cannulas. The nasal cannula, if too long, if too tight, might cause a pressure injury. Here there is some examples. As you can see in the first image, clearly printed in the baby skin, like if it's a mirror, the shape of the BiPAP. And in the other two cases, what I told you, that very easily it will become a stage 4 pressure injury with bone, and these patients probably will get a deformity for life or a scar for life. It will have some cavity even after it heals. They will have a mark that they have been in critical care and with a BiPAP forever. So intervention, very quickly. As I said, I spoke about the interventions through the presentation, but still to summarize and make sure that I didn't forget any, proper size of the device, in this case, speaking specifically about the non-invasive ventilation, in particular the BiPAP, proper adjustment, avoiding excessive pressure, wound dressing to reduce friction, shear, and moisture, like the hydrocolloid foam and gel pad. Even though to BiPAPs, I advise the hydrocolloid and gel pad more than the foam. But we need to keep in mind that this doesn't avoid pressure, okay? Those dressings avoid friction, which is important because we saw that friction, shear, and moisture are predisposing, are contributing factors to develop pressure injury, but the main one is the pressure itself. As I said, this is really important to use critical thinking to visualize your intervention. Who's accountable, who's responsible? Well, it was said very well in the beginning of this presentation, and once again, this is not to point fingers. There is no point to point fingers, no blame culture. Collaborative, united effort is the answer. Only with communication, collaboration, helping each other, we will succeed. I just want to finalize saying as well, I didn't want to, that there was much more that could have been said, like how to manage pressure injuries, but this is important, which I didn't brought in particular, but the Braden risk, you have this scale, Braden risk, even though in critical care patients, big majority of the patients will be high risk to develop pressure injury. It's really important to apply the scale, to understand, to be more aware, to have this deeper of the risk, who's more in risk, to prioritize our intervention, to prioritize if needed. Let's say you are overwhelmed, you have a cold blue, patient is choking, and you have 3-4 elements of the team more busy, and you need to cover 3 patients you need to prioritize. You should prioritize a patient that is high risk. In terms of this, I mean, of course, because there is, as you know better than me, there is complex and multiple comprehensive things that you need to look for. But in the point of view of the pressure injury, it's really important to apply Braden risk scale. And I'm done with my presentation. Thank you so much. Once again, my apologies for the delay and the technical problem in the beginning. I hope you enjoyed. Hope to see you next time if you have questions. I'm not sure if now is the moment or later on, but thank you very much.
Thank you very much, Mr. Carlos. Thank you very much.
Most welcome.
It was really a nice talk. And dears, if you have any questions, you can raise your hand within the coming 2 to 3 minutes. So give chance for Mr. Carlos, or if there is any question for Ms. Afrah, also you are free to raise your hand to ask question.
If I may, Agil.
تفضل أخوي سالم.
Thank you very much for Afrah and Carlos for this informative presentations. I really learned a lot and gained many insights of the respiratory related injury, respiratory equipment related pressure injury, and we know this is challenging. The Afrah presentation was looking at evidence on what is the best approach and what to do when it comes to intubated patient and how to manage a tube to prevent harm. With Carlos, non-invasive and the stages of the injury and the more detailed, extensive background of clinical experts like Carlos, we start to realize it's happening, it's everywhere. And I believe awareness, education is another important tool to have in mind. So I encourage myself, encourage everybody listening tonight to, when they go back to their workplace, to start to see what they can do to bring awareness about this unwanted harm. I also would like to point out this is from a quality point of view. Measurement is very important. I believe once you start to measure how many incidents you have, how many cases, and how many BiPAP or intubation or even tracheostomy care, any related respiratory devices, when you start to measure the application and measure the incidents, you start to realize it's there. But some places, if measurement is not available, you will not notice it. And so I encourage myself, encourage everybody also to really measure those cases. Early intervention is very important. So Carlos mentioned the right size, the right duration, the right cause. And especially I would say for the respiratory therapists, they play a very key role in this because they see the patient regularly, like the nurses. But usually when you put for example, the interface with the CPAP or BiPAP treatment, you can easily notice if you need to look for other solution, maybe change from nasal to total mask to helmet. We did not talk about the helmet. This is a new approach out there. Many hospitals are emphasizing in using it, and high flow is very important tool to use. So it's really a huge subject, but I congratulate Carlos and I congratulate Afrah for their amazing presentations. And I would like to hear from Afrah for a minute or two, summarizing all those evidence. Where do we stand in Saudi Arabia comparing to the international stage? And for Carlos, I would like to know from his experience if he could tell us how big is this issue in our institution and any other institutions he has worked on. And I thank them for their time. I leave the floor for them to respond. Thank you.
I'm sorry, Mr. Sam, can you repeat that question? It's
my question regarding your when you did your presentations and you were looking at the kingdom stand with the respiratory equipment pressure related injuries, and you look at the international, are we worse than or equal?
So
Yeah.
the studies I looked at were international studies. So they had rates of incidence and prevalence for internationally. So I didn't look at specific countries. I'm sure the hospitals are collecting this data. But the studies I looked at the international incidence and prevalence of each type of pressure injury. For prevention strategies, it's going to depend on the institution itself, what they are implementing to prevent the pressure injuries. And as you mentioned, it's going to depend on also collecting the data first to see where they are at. And from there, they can, based on their data, they can develop their intervention, develop the plan to prevent pressure injuries. From the literature, they can develop their plan. So it's gonna depend on each institution where they stand, but I looked at the international data.
From my side, I believe you finish, Afra, so if not, interrupt me, please. So from my side, trying your intervention or your question, in the specific case of National Guard, that for a while we had high rates when we compared even with the Middle East, but international, we were not performing very well in regards to pressure injuries overall, not specifically the respiratory device related ones, but even going to the respiratory device, there was a high rate of pressure injuries. And that was the reason that we started this project that was mentioned to prevent pressure injuries, the ones related to position, which is a little bit more nursing accountability, and the ones related to respiratory devices, which as we should be a collaboration effort. And we started 2 projects in National Guard. Many other efforts were done, and this change on the approach, that's what I really want to and to congratulate, to applaud the fact that we are here. It's showing me that we are in the right direction, and the data is showing that as well. For the last years, I'm not right now in pressure injury in wound endoscopy care team managing pressure injury, but I'm passionate about this topic, and I'm always looking on the data. How does it look like? And I can tell you that both sides, from the accountability area of the position directly one and other medical device, and from the respiratory one in National Guard, we are doing good job. It's decreasing consecutively for I believe the 3rd year, and this year it reached already very good numbers. It reached already rates that we can be proud. Yeah, that's it. I think only this way, having these sessions together, analyzing the problem together, trying to fight it together, and not blaming anyone, we will manage to solve this issue, because it's indeed a problem to the patient, a problem to the hospital. It's, as you said, a quality care indicator. It's a specific one for nursing. There is international institution and the NQI that do this job, collecting data and the standards to collect data in a systematic and standard way to benchmark international. Yeah, we are in the good way, I believe. Saudi is doing a great work and going in the right direction. So congratulations, if you allow me. And thank you very much once again to have me. It's my pleasure.
Thank you very much, Mr. Afrah, Mr. Salem, Mr. Carlos, for your nice discussion. So, do you have any other words or something to say, Mr. Salem?
Not sure if we can open the mic for the audience. Can you see if you can open it for everybody?
they can raise their hand. Then the one who want to talk or to ask will be given an access. But there is no actually no one.
طيب fine. على كل حال السعودي Critical Care Society RT chapter is your home, and I say this with all honesty. We are a team of volunteers to serve the healthcare from the respiratory perspective. Please join us and share with us your concerns, and we will do everything we can to enhance the profession, to provide better healthcare. Nursing to us are like brothers and sisters. We cannot work without them. They are great people. They are very supportive. Carlos, for example, it didn't take me a minute to buy him in. I just told him, and he says, I'm in. And he left his other task to be with us, and I thank him so much, and I hope, inshallah, we will see him again and again. With this from my side, I don't have much to say. Shukran, Agil, and I leave the rest to you and the team. Shukran, Jazeel.
Thank you, Mr. Salam. Thanks all of you for your attendance, and hope to meet you again in another session, either webinar or any coming course. We just opened this year by this webinar, and hopefully, inshallah, we'll meet you again in other sessions. Thank you very much.
Thank you. Bye-bye.
Thank you.